Hi, welcome. This is Patty Osborne Schaefer from the Epilepsy Foundation. I'd like to welcome everyone to today's webinar on early death in epilepsy, focus on SUDEP. Right? This webinar is being done as a collaboration between the Epilepsy Foundation and the American Association of Neuroscience Nurses, and it's part of the National Epilepsy Education and Awareness Collaborative. The program's made possible with funding from the Centers for Disease Control and Prevention under a cooperative grant agreement. Its contents are solely the responsibility of the authors and don't necessarily represent the views of the CDC. So during the format of this, I'd like everyone's lines to be muted. You can type in questions at any point during it, and we'll be having a question and answer time in which you can also unmute yourself and ask questions. Please keep the questions in general. You know that we can't give out general individual medical advice at any time. So for the objectives of this talk are to help us as nurses and other healthcare providers identify the risks for early death in SUDEP in youth and adults with epilepsy, to be able to incorporate strategies to enhance safety during seizures and help lessen the risks of early death in people with epilepsy, and then describe approaches and resources that can enhance patient and provider communication about SUDEP. I think as nurses, I think we are really kind of at that front line, and we often hear some of the most intimate questions from people with epilepsy and their family. We might hear their fears, their anxieties about things that they might not feel comfortable sharing with their doctor or other healthcare providers. So I think it's very important that we understand early death in SUDEP, and we think about our role and how can we help enhance that and make sure that the whole team is understanding and has that chance to talk with the patients and families about SUDEP. Because we clearly know that, dying early from seizures is on everybody's mind, and it's best to really address this early. And Dr. Devinsky will talk a lot about that today. So for our lineup, we're first going to talk with Tom Stanton. He's the Executive Director of the Danny Did Foundation, followed by Dr. Orrin Devinsky, Professor of Neurology, Neurosurgery and Neuropsychiatry at NYU School of Medicine and Director of the NYU Comprehensive Epilepsy Center. And then myself from the Epilepsy Foundation, and Dr. Brandy Fuhrman, Vice President of Research and New Therapies from the Epilepsy Foundation. And the speakers have no conflicts to disclose. So I'd like to invite Tom to unmute himself and to talk to us first from your perspective about SUDEP.
Thanks, Patty. I just want to start by thanking the Academy for making time for this important topic. It's really, like Patty said, having nurses on the front line that have a lot of these conversations with patients and parents makes it especially important that we talk about SUDEP with nurses. So I just want to give a background on my personal story to kind of ground this conversation. So on the screen here, you can see my nephew, Danny, who was the third of 4 siblings. He had 2 older siblings and a younger brother. And he had his first seizure around the age of 2. He had no other medical complications. He was a affectionate, smart, athletic little boy, and really on par as far as all of his peers. So his first seizure was during sleep, and they went to the ER like a lot of families do after the first seizure, and he wasn't put on medication, but they were kind of sent home and told to be vigilant for any more activity. He had about 4 more seizures over the next 2.5 years that his parents witnessed. So a pretty low volume, and they were all during sleep. He had been put on medication and was fairly well controlled, relative to some other kids. And he had, like I said, he had no other medical complications. So, sleeping was very difficult for his family. They had a lot of restless nights, constant bed checks, a lot of co-sleeping where Danny would go into his parents' room for months at a time after a seizure had occurred, just because of the fear of missing the next one. So fast forward to a few months before his 5th birthday, Danny had been to the neurologist for a routine checkup on a Tuesday morning. And other than slight modification to his medication based on his weight gain, they were getting a good report that he is on the right path and that they should stay the course. And then 4 days later, on that Saturday morning, his mom found him in his bottom bunk bed and he was lifeless. And there was a mad scramble to revive him, but he had died. He had died just 3 months before his 5th birthday. So the first time his parents had learned the term SUDEP, sudden unexpected death in epilepsy, was on his death certificate. They had never had a conversation with a doctor or nurse or anybody from their healthcare team about that particular risk. And so, as you can imagine, they felt blindsided, just not having known that this was possible. This was on the spectrum of possible outcomes. And so they decided to start the Danny Did Foundation to try to fill some gaps that they experienced during Danny's treatment. One primary gap just being that communication between healthcare providers and parents or adult patients about the risk of SUDEP. And so the name of our organization comes from the last line of his obituary, which read, "Please go and enjoy your life. Danny did." And so now we try to have this spirit of optimism and possibility and hope. And Danny, his new place in the world has become our foundation. And we spend a lot of time trying to raise public awareness about epilepsy and the risks that come with it. That's kind of our experience. And in the 10 years since we've been running the foundation, we've met too many families that have had a similar experience where they had never heard of the risk of SUDEP or other types of mortality that exist for people with epilepsy. And so just the kind of personal experience from our family that it is so important to communicate with patients and to have that open, honest conversation. And we really feel like it engenders more trust, more honesty, and will ultimately be a benefit to the healthcare team to have that frank, open, honest discussion. And a lot of you, I'm sure, are parents, and that we digest difficult information all the time, and we can handle it. Of course, it can be upsetting, or it can be a lot to take in initially, but it's really necessary for us to make the best treatment plan possible to have the full information, the full range of possible outcomes. And unfortunately, that wasn't present for Danny. And we wish that it was, but now we're trying to change the dynamic and make it more common where a family or an adult patient would hear about the risk of SUDEP and have a chance to modify their treatment, make sure they're adhering to all the treatment that they're being advised on. And it's just a key issue for so many families. And I urge you to just continue to do your part to share that information when you can. Obviously, the context is important. We always talk about doing it in the context of other safety issues or other risks that may be discussed with the patient or with the parent, just asking not to leave SUDEP off of that list. So appreciate the time and the chance to share our story.
Thank you very much, Tom. And now I'd like to introduce Dr. Orrin Devinsky to talk with us about some of the myths and the facts about sudden death in epilepsy.
Thanks so much, Patty. And I also want to thank the Epilepsy Foundation and CDC for the opportunity to present and try to give some information about what is unfortunately a terribly under-recognized disorder. So next slide. As Tom hinted, when we think about SUDEP, I think to take a step back, it's worth thinking about death among people with epilepsy, because unfortunately, SUDEP is perhaps now the most well-known cause of death, premature death among people with epilepsy. And indeed, if you just take a group of children, young adults with epilepsy, and compare them to other people in the general population from their area and their age group and sex, people with epilepsy have an approximately 27-fold increased rate of dying suddenly than the general population. And in one very well done study in Finland, they looked at a group of people in a community who were diagnosed with epilepsy, and actually, because people in that country stay there pretty much, they were able to get good follow-up over 40 years. Of the people who died, 55% of the deaths were a result of epilepsy. With SUDEP, of those 55% of deaths from epilepsy, some died from cancer and heart disease, and that was the other 45%. But SUDEP was an important cause. Seizures or status were an important cause, and then drowning was another cause. So there are unfortunately many ways that people with epilepsy can die. They can have a seizure driving, they can have a seizure swimming, fall down a flight of stairs. And then a single seizure in bed, as I'll get to, can unfortunately be deadly. Another important fact is that the care of people with epilepsy in the United States, sadly, tracks with income. People who are wealthier tend to get better care. And in lower socioeconomic groups, this was from a study done in Ohio, young adults with epilepsy die 17 years prematurely. And to put that in perspective, cigarette smoking probably reduces lifespan by 5 to 6 years. In this group of Medicaid patients in Ohio, epilepsy reduced lifespan by 17 years. So there are other ways to think about this, but overall, this is from a study done in Europe. There are natural causes of death, which include SUDEP and others, are about 15-fold more common. But external causes, which are what are listed here, suicide, falls, drowning, car accidents, drug poisoning, assault, all of these, unfortunately, all of these causes of death are more common among people with epilepsy. So I think the conversation that Tom was referring to, I fully endorse. I think SUDEP should be the leading thing because that's probably the most preventable one. But breakthrough seizures due to someone missing one dose of medication can also result in a car accident, can result in a fall, can result in drowning. And unfortunately, lack of diagnosis of depression and treatment can increase the risk of suicide for these people. Next. So what are the risk factors for SUDEP? And these come from, we now have a wealth of studies that have been done in multiple countries across multiple decades. And the single leading risk is individuals who continue to have seizures, especially as measured in the last year, and particularly generalized tonic-clonic seizures, or what are known as colloquially as grand mal seizures. In addition, seizures that occur in sleep, especially tonic-clonic seizures, but other factors like a known cause for the epilepsy, a previous history of stroke or an infection, those would be symptomatic causes of epilepsy. Patients who tend to run anti-epileptic drug levels that are below the therapeutic range, patients who are on more than one drug, often 3 or 4 drugs. This may simply be a marker of the severity of epilepsy. Obviously, the reason neurologists would put people on 3 or 4 drugs is because they didn't get controlled on 1 or 2 drugs, but there may also be some additional risk from high doses of multiple medications. Early age of epilepsy and long duration of epilepsy, which tie together, are also risk factors. The longer people have epilepsy, unfortunately, the greater the risk they could die from SUDEP. And in some studies, male sex and intellectual disability also make SUDEP more likely to occur. There are some factors that are associated with a lower risk of SUDEP as well, and these include patients who are seizure-free. These include patients who, during the nighttime, either share a bedroom with a sibling or a spouse, or are supervised, for example, in group homes or larger facilities for individuals with developmental disabilities. Some of those have excellent monitoring systems with sound alarms and cameras and resident advisors coming by to check in on the patient. And they have much lower rates of SUDEPs than similar places that don't have that monitoring. And in an analysis of something like 20 different trials of patients with severe epilepsy randomized to get a new drug or a placebo, those in whom they got the new drug had a much lower rate of SUDEP. Again, speaking to the same message over and over. controlling seizures will reduce the risk of SUDEP. Next slide. So one of the common scenarios for SUDEP to occur is when someone's alone. In looking at a number of different series, in about 86% of cases, SUDEP is unwitnessed. And we think a lot of this simply reflects that if a seizure occurs and a parent or a spouse or a brother or a nurse is around, intuitively, people provide a basic level of first aid. If someone has a seizure and rolls face down with their head into a pillow, for example, any bystander would know to roll that person on their side and have their airway be free. In the same way, they'll often be stimulated slightly by calling the individual's name. Are you okay? Are you okay? And that kind of simple intervention is probably life-saving in many cases, where if that person happened to suffer a seizure with a prolonged post-seizure state of depression, which I'll get to, and no one's around, it can be fatal. And if someone's around, they roll them over, stimulate them, and the patient comes out of it. About 58% of SUDEPs occur in sleep. So keep in mind, sleep on average, if we're lucky, is about 1/3 of our lifetime. If we sleep 8 hours, that's about 1/3 of our life. But it turns out that SUDEP in sleep is about 60% of all cases. So it's actually a majority of cases, even though sleep is a minority of our time. And in some other studies, if you have a history of nocturnal seizures, SUDEP in sleep is about 3.5-fold more likely. And again, compared to living controls with epilepsy, nocturnal seizure history is a risk factor of almost 4-fold. The prone position, which means face down, is highly correlated with the risk of SUDEP. So seizures that probably, not that people are sleeping on their belly, we think it's much more likely that people were sleeping on their side or their back or their belly, but at the end of the seizure, they were left in a face down position. And again, if you're under age 40 and found in the prone position, it's again a significant risk factor for SUDEP. Next slide. So we have gained a fair amount of information from epilepsy monitoring units. And what this slide summarizes is that, all throughout the world, patients go into epilepsy monitoring units for many, many different reasons. Some people go in to have seizures recorded so doctors can localize and lateralize where they come from in the brain to see if epilepsy surgery would be a possibility. In other cases, they come in to see, is it epilepsy? If it is epilepsy, how frequent is it occurring? So these are patients who have gotten admitted who actually, unfortunately, had a SUDEP in an epilepsy monitoring unit. And there are some common features. All of them followed tonic-clonic seizures. In addition, there were 9 cases that would have likely been SUDEP had intervention not occurred. 7 of those followed tonic-clonic seizures. 2 followed what used to be called complex partial and are now referred to as focal unaware seizures. And the mechanism we think of what goes on is that after a seizure, the brain kind of shuts down. And in that shutdown mode, there's a lack of breathing because you need the brain to trigger respiration. You don't need the brain to keep the heart going. The heart will run on its own, but you do need the brain to trigger breathing. In addition, if the brain is in the off position, all of the normal arousal reflexes that we have are also off. So again, in kind of not an elegant metaphor, if someone came into your bedroom at 3 a.m. while you're sleeping and put their hand over your nose and your mouth, your carbon dioxide levels would go up, your oxygen levels would go down, sensors in your brainstem would get very activated, you would arouse, you would wake up and immediately start fighting off the person who's putting their hand over your mouth and your nose. But if someone came into your bedroom while you're sleeping and took a baseball bat and hit you hard enough that you were fully unconscious from that injury, and then put their hand over your nose and your mouth, you'd be in big trouble because your ability to arouse and respond would be greatly impaired. And on the bottom of this slide, this has actually been revised a little bit. There are now 3 cases, we had one of them that had been reported where a SUDEP occurred without a preceding seizure. I think these are extraordinarily rare cases. We don't know what caused the individual with epilepsy to die. but it has occurred, and clearly is a tragedy. So keep in mind, SUDEP probably can follow less severe seizures, and rarely it can even occur without a seizure being documented while someone has an EEG recorded. What's common to all of these cases, however, all the SUDEPs, they were not observed. So no nurse, no doctor, no one was watching a TV screen of these patients, or if they were, in cases someone may have fallen asleep and during the night shift, something like that has happened. Keep in mind, many of these cases have probably occurred, but for medical legal reasons, the hospital, doctor, or family has not wanted this case reported. Next slide. And this just gives you a bit of an image of what I was referring to. The figure you see there is an EEG, and in the left part of the panel, you see a series of epilepsy waves or jerks, and then there's muscle activity at the end, and then at the very end after that, the second half of the recording, you see a very flat EEG. There's some movement there, but that's, I think, positioning by a healthcare worker trying to attend to the patient. But the important thing is, and you don't need to be an EEG reader, but the tracing is basically gone flat. And this has been referred to as postictal generalized EEG suppression, or PGES, and it correlates with the patient being in essentially a comatose state. During this period, respirations reduced, and one of our colleagues, Sam Latu, did a study back about 9 years ago, where if that duration of EEG suppression lasts more than 60 seconds, there's a 30-fold greater risk that that person could go on to suffer a SUDEP than from someone who had a tonic-clonic seizure recorded with a much shorter duration of EEG suppression. This has not been universally validated, but one of the reasons is that in some of the validation studies, I think those patients got better care by the nursing staff. So nurses got to the patients more quickly, and we never really got to see what the EEG suppression would look like, because we know that if you stimulate a patient or roll them over, you tend to shorten the duration of EEG suppression. So I do think this probably is a true marker, and probably is related in some cases to the mechanism of SUDEP, because the brain essentially is in the off position for a long time, and that's going to put people at risk. Next slide. So who is at risk for SUDEP? And I think an important message is that everybody is. Clearly, the risk does track with the severity of epilepsy, and it does track with the frequency of tonic-clonic seizures that have occurred recently, for example, the last year. But unfortunately, I believe it's likely that there are people who their very first seizure caused SUDEP. They were never diagnosed with epilepsy, so it would never be called SUDEP officially. A good example of this is children with febrile seizures. I'm also involved with an organization that studies sudden unexplained death in childhood. These are children typically between ages 1 and 5 who almost all die in sleep, who almost all die unwitnessed, and fully a third of them have a history of febrile seizures, roughly 10-fold greater than the general population. None of those cases will get categorized as SUDEP because they're febrile seizure patients, and febrile seizures is not considered epilepsy. It's considered more a seizure disorder, so no one would classify those currently as SUDEP. But we do think some of these kids have literally had their second febrile seizure of their life that was probably unwitnessed and probably led to death. So we did a recent study, and I should say from population-based data in countries like Sweden and the province of Ontario, the risk overall for all children and adults of SUDEP, if you just take everyone with epilepsy, it's about 1 per 1,000 patients per year. That probably goes up to 5 to 10 per 1,000 patient years in those with the most severe forms of epilepsy. And just to put that number into a little bit more context, for the average person with epilepsy, it's about a 1% chance that SUDEP could claim your life over a decade. For those with the most severe forms of epilepsy, it may be 5 to up to 10% chance that SUDEP could claim your life over a period of 10 years. So we here at NYU have a North American SUDEP registry, which is a collaborative with many of the other people you're hearing from today. And over the past, I think, 7 years or so, we've collected 237 SUDEP cases. And as you can see, and I'll summarize, 40% had generalized epilepsy, 60% had focal epilepsy, which very much matches the distribution in the general population. And it affected the full spectrum of people with epilepsy. There were children with benign Rolandic epilepsy, typically not on medications because it was felt seizures are not common. Childs always outgrow that form of epilepsy. But unfortunately, one seizure at the, in sleep could be deadly for that group of patients as well. In our series, 93% were unwitnessed, 70% occurred in sleep. 69% of those patients who died in sleep were found with their face down. Only 37% of cases took their last dose of anti-seizure meds, according to family members, spouses, et cetera, who could track that. And I just to hover on that point, that's the place we could intervene most. And I think that's where nurses could literally save lives. If we can impress on people how important it is that they're in control in many ways of their seizure freedom, not always and not fully, but for most people they are. If they get good sleep, if they avoid excess alcohol for adults, and if they take their seizure medications, their chances of SUDEP go down dramatically as best we can tell. And finally, in this group, a lifetime history of tonic-clonic seizures was under 10 in 33% of all the cases. So many of the people who die from SUDEP are not those who have had 20 or 50 or 100 convulsive seizures, but many had less than 10. And the number was 0 previous tonic-clonic seizures in 4% of these cases. So even people who have never had a convulsive seizure in their life, sadly, are still at risk for SUDEP. Next slide. So this just summarizes the experience with benign Rolandic epilepsy. And I think it's important because, pediatricians, pediatric neurologists will routinely tell parents, you don't need to treat these kids. And indeed, still in most European countries, in Canada, I would say a very large percentage of these kids, and some in the United States, are also not treated. And it's not an unreasonable decision. It's not that SUDEP is common in this group. It's just that SUDEP can occur in this group. So we saw 3 children among the first 190 Nassar cases. 2 were definite, 1 was probable. The probable just means there wasn't an autopsy to confirm that there was no other cause. But again, these were young kids and extremely unlikely that it was anything other than SUDEP. They all had benign epilepsy of childhood with centrotemporal spikes, or benign Rolandic epilepsy, as it's also known commonly. All 3 of these patients were on no medications, either because the doctor said you don't need it, or because the discussion between the parent and the doctor was like, listen, given I'd rather not have my child on medications every day, I'd rather tolerate 1 seizure a year or once every 6 months or 2 years. And all of these died in bed during sleep. And they span the severity. Some were a little bit more frequent, and some had very rare seizures for this syndrome. So again, just speaks to the fact that everybody with epilepsy, children, adults, well-controlled, poorly controlled, unfortunately, no one's immune from this horrible problem. Next slide. So as a community, I know we like to pat ourselves on the back and say what we've done. I think for SUDEP, it's what we failed to do. And I think so far we still haven't done very good data on SUDEP with regards to its frequency. One of the things that gets disorders funded is knowing what the frequency is. So for example, if someone dies at age 55 with a history of seizures, is found dead in bed in the morning in a classic SUDEP scenario with their face down, I would say 95% of the time medical examiners will call that cardiac or something else, because they're over 50, and when they look at their hearts, they'll find some plaque and they'll say it's cardiac. And I think that's wrong. And we've worked and published several papers on the underdiagnosis of SUDEP. I think we as a community need to work better with medical examiners, and we've done that. I think very importantly, we need to educate our neurology, pediatric medicine, and obviously what we're doing here, nursing and nurse practitioner colleagues. We need to educate families, because as Tom's case and so many others, the majority of Nassar cases too, the families had not been even told that SUDEP was possible. And we need to reduce the SUDEP risk through targeted prevention. I think simply working on better medication adherence, educating patients so they understand what the consequences may be of not taking meds, and the good news is there is evidence that we have from some different jurisdictions, the state of Maryland, New York City, and San Diego County, where we have excellent data, that the rate of SUDEP has declined a bit over the last 7 years, and that's going to come out in neurology shortly. Next slide. And then this summarizes some work a colleague Dan Friedman did together with a number of other investigators, how frequently neurologists discuss SUDEP with patients. And it turns out 12% never ever talk about it, and only 21% talk about it more than half the time. This slide is from a survey about 5 years ago, but I fear that this has not changed a lot. So I think, you know, we on the medical side need to do much better, but fortunately our colleagues in nursing tend to be much better at communicating with patients. So I think you can help us out tremendously, and I think that help can be life-saving. Next slide. So again, how do we frame this? How do we tell patients and families about this? So one way to think about it just for us is that SUDEP kills as many Americans, it's at least 3,000 a year, and I think that's an underestimate, as fires or sudden infant death syndrome, which is actually down to about 1,600 now in the US. There are 315 million Americans, except for the very young, who are educated about fire safety, and pretty much every parent has heard about SIDS, but sadly, most people with epilepsy still are not educated about SUDEP, which is something simple things we can do, like taking medication, avoiding sleep deprivation, could be life-saving. So I think the disconnect here is enormous. You know, we have 340 million Americans educated about fires and every parent knowledgeable about SIDS, but we have the 3 million people with epilepsy in America terribly educated about SUDEP, which is something that can take their lives and something that they can take simple measures to reduce the risk of tremendously. Next slide. And again, just a couple more. This makes some of the points that I made from the Ohio Medicaid study. Poor populations, unfortunately, have much higher rates of SUDEP. In New York City, my colleague Dan Friedman tracks SUDEP with socioeconomic status, and it's a perfect correlation. The poorer you are, the more likely you are to have SUDEP. And that's a healthcare disparity. So for example, in 2013, the National Institutes of Neurologic Disorders, part of NIH, awarded $40 million to educate patients in high-risk populations, for example, Blacks in low-income areas who have high rates of hypertension that put them at risk of stroke. And education, going to barbershops and letting people learn about it in their community, has been very effective. To date, I'm not aware of any money that's gone to reduce epilepsy disparities with regards to things like SUDEP education. And again, national priorities, SIDS claims, I think that was a few years ago, about 1,560 lives per year, has received more than $500 million in the last 20 years. SUDEP currently claims at least 3,100 lives a year and has received less than $75 million during that time span. So I think we also need to do better to get more funding. Next slide. And then finally, SUDEP myths. So SUDEP only affects those with treatment-resistant epilepsy. Wrong. SUDEP only occurs in sleep. Wrong. It can occur in wakefulness. It rarely affects kids. We used to think that's true, but more recent, really nicely done population-based studies show that it's just as common in kids and as adults. SUDEP can only occur with a preceding seizure. That's usually true, but it is definitely not always true. And then there's nothing you can do. Doctors have been nihilistic about this, neurologists, like, why should I tell people if they can't do anything about it? Well, that's wrong. You can do things about it. Patients do things that prevent seizures, like take their medications regularly and get good sleep. They probably can prevent SUDEP. That may be it. Next slide. Is it? Yep. So thank you very much, Patty, and everyone else.
Thank you very much, Dr. Devinsky, for really getting this stage set here and sharing such valuable information. And it really reminds me of how much nurses can do to really help really prevent early death and help people talking about SUDEP. So I just want to share a few thoughts about, as a nurse, what's our role? And the first thing that I think, when we're working with patients and families, we're always asking about seizures, but are we really assessing their seizure control, and what words are we using? So how do we define seizure control? If you look at the literature, you know, and even as you talk to patients and families, I'll make a bet that you're defining seizure control differently than they are. I've been involved with studies looking at social media and qualitative work, and people with epilepsy and families often define their seizure control in terms of the impact or burden on their life, and not necessarily by numbers of seizures. And so that's important to think about, and have very specific questions when you're talking to people. And also be specific in terms of talking about their types of seizures. We've heard how important tonic-clonic seizures are. So oftentimes we just say, well, how are the seizures? Or have you had any recently? But we should be asking, what kind did you have? And better yet, can you tell me what happened? Because tonic-clonic, it means big seizure to a lot of people. And so they might be thinking maybe a big focal impaired awareness seizure and not a tonic-clonic, or vice versa. And if it's short, they might call it a small seizure just because it's short, or maybe it didn't, you know, have as big impact. So I think the more specific we can be in our language as we assess seizure control is critical. And then also checking, are we using the names? As a community, as we are now changing names of seizures, we have to be very careful of what the words are, using older terms as well as newer terms, and again, getting the descriptions of what happens. I think an important part of that is that oftentimes people don't tell you if they have aurors, or they might say that they have a tonic-clonic seizure because they think the other stuff might not be seizure symptoms, when in fact maybe it is. So being as accurate as we can. And then also asking, we'll often say, gee, is there anything triggering your seizures? And people mix up the term trigger to causes a lot. And so we might not be speaking the same language when we talk about that. So just saying, are there any patterns to your seizures? Do they happen at night or in the morning or any time of day? You know, and then also asking, where does it happen? Because what about people who, you know, are sleeping but maybe not in their bed? So ask it, is it happening, you know, not just at night, but when you're sleeping? Because what if they work at night, and they might think, well, it's not happening at night because I'm working, but it might happen during the day when they're in bed. The other thing is to think about, how can we help people maximize seizure control? And let's all keep in mind that kind of definition, or when we should be referring to epilepsy centers. So regardless of the cause, if someone's had a seizure because of a stroke or a tumor, and maybe you're seeing them and you're in a stroke center, or you're in general neurology, or wherever you're at, if they're still having seizures after 2 drug trials, they should be seen at an epilepsy center, if not just for a consult. Or if you think that they're at higher risk for SUDEP, that's a very proper reason to have a referral to an epilepsy center, where they can get more testing done and really better learn what their risks are and what could be done. As nurses, I think we're dealing with treatment adherence all the time. I always need to stress to myself as well as others to think about the cause of what the problems are in managing their medicines. So is it that we've made their medication regimen too, you know, complex, too many times a day, too many different pills? Can we simplify that? Can we get them at a long-acting form? You know, and we don't often realize how complex the regimens are made unless you ask someone, is this easy enough for you to do, or what could make it easier? And the other is, I mean, we all know it, providing clear and simple instructions, but how often when we're busy, we tell people what to do, or maybe we scribble down a few notes. But when you get home, I know when I leave the doctor's office, I'm often thinking, okay, there were so many things going on. Exactly what was it I was supposed to do? And if I didn't write it down, or someone didn't give it to me, I'm at a loss, right? And then next is, we have medicines coming in different forms. A rescue therapy might be an inhaler, you know, it might be under a tongue. We might be using liquids for kids. So demonstrate as much as we can. So we're not just assuming that people understand the instructions. And then keeping in mind, it's not just the act of taking medicines. One of the biggest problems with adherence is people can't afford it. So do you have a social worker handy? When anyone's ever started on a new medicine, can the social worker check in with them? And can they afford it? Are there big copays? What are the issues that they could help with, right? And are there ways to access medicines easier, getting home delivery? Or what I like to think about is getting a home health assessment in the home if someone's got problems managing the medicines, and think about what devices that can help keep track of dispensing medicines and make it a lot easier in the home setting. And then just having their home healthcare referral to look at other causes. If the person's got visual problems, mobility problems, they can't pick up the pills. We might not know that in the office, but somebody who goes in the home can. So beyond looking at the adherence, I think we've got to look at managing triggers and safety. What are those opportunities for change? So does someone have any consistent or modifiable triggers? Are the person willing or able to make changes? And then what type of change might be needed? Is it a behavioral change, an environmental change, or maybe more support that's needed? So someone who has seizures at night, what kind of change might be needed there? And is it doable change? If it's their work hours, it might not be doable change, but there may be some options. And in looking at triggers and safety, we've got to look at the living situation. Dr. Devinsky talked about living alone versus living with other people. But, the functional status, what's their cognitive function? Again, I just mentioned mobility function. Other things that can be causing problems with taking medicines can also be causing problems with managing triggers or making sure that they have a safe environment. So those are just a couple of examples of enhancing seizure control, but how can we enhance safety? So we want to get help to people as soon as possible after seizures. So how can we do that when seizures at night? So I think about timely response to seizures at night. And if I date myself and think back years ago, we used to say, single seizure is not a problem. And we used to tell families, you don't need to room in. Well, this data may be changing our opinions, and we need to think about how can you get proper first aid available to the person, if they need a rescue therapy, if it's prescribed, who can give it, how do you prevent the complications like getting someone onto their side and not, leaving them or letting them stay in a prone position. So again, sharing a bedroom, if that's doable, or using a seizure alert device so someone can sleep in their own bed but be notified if a person has a seizure so they can get to them quickly. And then just to go back to thinking about, if you have sleep-related seizures, look at other triggers the person has and how do you minimize a lot of things going on at once. If they have nighttime seizures in early morning hours, is there a change to their medication schedule of what time they should be taking medicines or getting a long-acting drug that gives them better protection throughout the night? And then we have to think about the fact that not everybody lives with someone else. They're not all with family. They may not have friends available. So the need is the same, but the strategies might be different. Can they share a living space? So if someone has their own home, can they rent out part of their house? Or can they look for an apartment with another person and they give kind of a discount on rent or something if that person's available, maybe to be someone that could be alerted? Can you talk to them about what seizure alert devices are? And is there a family or a friend offsite that could be notified by a seizure alert device if they have a seizure? That person could call them to see if they're okay, or even just call a community 911 to go check on them, right? And then the other thing is if you live alone, I know with my parents when they were getting older and other illnesses, I wanted to have a check-in with them just to make sure it was okay. And if I didn't hear from them, I needed to institute that check-in. And we should think about that same thing for people with epilepsy who live alone. And obviously, we think about seizure and an emergency, break glass, get help right away. But what can we do short of calling an ambulance? So I have just a couple slides just to highlight a few examples of devices that, we'll share these handouts with you afterwards, but all of this information is also on Danny Did, and we have information on some of the devices on epilepsy.com. We've got brochures available from Danny Did and Epilepsy Foundation too. But the first thing to think about is, what's the device intended for? Is it to recognize seizure? Is it to just track the number? Will it alert? And what else can it be used for? So if someone's got respiratory problems, that's monitoring their pulse oximetry, is that helpful for someone who also might have tonic-clonic seizures and has respiratory problems? So are there things that could be used for multiple reasons? If you're using a seizure alert device, you need to know what type it captures. Most of them are really capturing seizures with movement or repetitive movements, which works with the tonic-clonic seizures, but not with the focal seizures. Understanding how it works, whether it's a video, whether it's a phone, that all makes a difference to see what would work best in a person's environment. They need to know whether special equipment or training is needed, and particularly is internet access. So usually the data is sent up to the cloud when messages are then sent, wirelessly to other phones or systems. And so that means someone needs internet access. And not all of many people in our country still don't. And then clearly the cost is a factor for these devices. Insurance doesn't cover them for a lot, or the person with epilepsy or their family needs to institute that insurance coverage. There might be large out-of-pocket costs or subscription rates. So you need to think about what those are. Is there help to afford those? Or does that put it out of bounds? I'm going to skip over this other than to say EEG systems are being developed for home use. So, the Zito is a way of a wireless headset that you can check EEGs and monitor if stuff's going on in primary care settings. It doesn't have to be in an EEG lab. And this epilogue patch, I'm going to ask Dr. Devinsky or Tom to comment on this in the discussion if this is available yet, because I haven't been able to find it commercially available. But it's a single EEG patch that can be placed with the scalp line and help record and monitor seizures. We also have Mattress Devices. These are made through the United Kingdom, and they detect repetitive movements, but that could be helpful for tonic-clonic seizures, and that sends the message to another person to allow them to maybe get to the person sooner and check on them and provide basic first aid. Okay? The SAMI, or sleep activity monitor, is a video camera, so that could be very helpful for people who are homebound or people who have seizures at night, and that you can record and analyze the abnormal movement. You do have to adjust the sensitivity to detect minor movements. It doesn't pick up all kinds of seizures. So again, you need the discussion with your healthcare provider as to which one would work for you. And then we have all sorts of watch devices. The smart watch now has a version Inspire, which this detects and records movements, repetitive shaking, so it doesn't capture all kinds of seizures. This used to be just a watch that you could get, but the software can be put onto any kind of smart watch, and I believe an Android or an iOS. And it can record sound as well as heart rate, beginning to do sleep and activity tracking, and then that can send alerts. Well, again, there's subscriptions and some insurance coverage, but certainly something that could be looked at. As well as the Embrace watch by Empatica, that detects convulsive or tonic-clonic seizures, but also records other physical data. And so that could be helpful for other seizure types in the future. Right now, it's approved for convulsive or tonic-clonic seizures. And again, can link to other diary to record, but can alert people. And then the newest is Seizure Link. I don't know if anyone's using Brain Sentinel with the Speak system, where you can have this device placed on the biceps, and it's used as a diagnostic tool in hospitals. So you can actually monitor someone at home. The information goes into the EEG lab or the physician reading the EEG, and they can look to find out if these events are seizures. The consumer version, called Seizure Link, is just for monitoring, not diagnosing symptoms. So it's EMG based. You can see a picture of it placed on the biceps. It's wireless recording, can record the suspected tonic-clonic, and my understanding is it can send warnings to up to 10 people at a time. So I think when we think about this, there's a lot of nursing implications here. We should be thinking about these devices. Does that give new opportunities for enhancing safety, reducing risks? Can we use these in our teaching sessions and educating patients and families about reducing risks? Don't wait for others to start these discussions. As we talk about safety, we can talk about these risks. These devices do not decrease risk of SUDEP. These are here to alert and record for seizures with goal of controlling seizures better, of decreasing risk for SUDEP. And then we always need to think about balancing a person's desire for privacy and independence with the needs for safety and seizure control. So I apologize for the technical glitch there, but I'd like to turn to Brandy Fuhrman, Vice President for Research and New Therapies at the Epilepsy Foundation, to talk about the SUDEP Institute.
Hi, thank you, Patty. I appreciate everyone joining us today and spending your time to learn more about early mortality and epilepsy. I'm here really on behalf of Sally Schaefer, who is the director of the SUDEP Institute and is part of my team in the Research and New Therapies group. And she is actually traveling to raise awareness about SUDEP today, so she wasn't able to join us. But I wanted to share with you that the SUDEP Institute can be a resource to you. The foundation started the Institute in about 2013, and the purpose was to broaden awareness and education about SUDEP and other causes of early death in epilepsy, and to try to find ways to prevent that from happening. We really want to try to empower people living with epilepsy to have more information and knowledge so that they can try to reduce their risk whenever possible. I want to say a word about Sally, who is the director. Sally had professional experience in the healthcare sector, but she also brings personal experience to this position, and it really drives her passion for the work of the SUDEP Institute. She is the mother of 3 children, one of whom had a rare epilepsy and had special needs as a result of that. And unfortunately, her daughter Lydia passed away about 5.5 years ago on Mother's Day. And that experience is something that Sally brings to her ability to drive forward the mission of the SUDEP Institute, but also connect in a very powerful way with other families who have experienced loss. So the SUDEP Institute both educates families and individuals living with epilepsy, healthcare providers, and researchers about SUDEP and the need to develop new ways to prevent SUDEP. We also drive forward research in this area. We're hosting a research summit this coming June, and we also offer a biomarker challenge. And the idea of the challenge is to offer a prize for a research team that can offer predictive validity of a biomarker that would measure someone's risk for SUDEP or life-threatening seizures. And we think that that could be a real game changer in the development of ways to prevent SUDEP. But we also offer bereavement support to families. We have a bereavement support specialist, Kelly Jankowski, and Kelly has also lost someone to SUDEP. She understands this loss, the suddenness of it, and how tragic it can be, and is also available to connect with families who have experienced this. We also offer a secure and safe online support group where people can connect. So I'll just close by saying we're really thankful that you are here to learn more about SUDEP, and we hope that you will take away with you that the SUDEP Institute can be a resource to help you. We have support materials and patient information that we can gladly send to you, and you can contact the SUDEP Institute either through the page on epilepsy.com or through sudep@efa.org. Thank you so much, and Patty, I'll pass back to you.
So I'd like to thank our panel today for all the wonderful information and for everyone who's attended this. I think obviously, mortality in epilepsy and understanding SUDEP, one of the most common causes, is critical. And I hope that there's some takeaway points for everybody that you can think about for your practice. I think the fact that we're able to talk to you as all neuroscience nurses is so important because seizures happen for a whole host of neurological reasons. And as I heard Dr. Devinsky say, symptomatic causes of epilepsy place you at greater risk for SUDEP. So stroke, head trauma, tumors, any of those things that have a symptomatic cause for seizures, patients there will have a higher risk of SUDEP. Right? So again, I thank the American Association of Neuroscience Nurses and the CDC for helping us put on this series of webinars, and I hope that you found this helpful. Thank you and have a good day.